Okay, so thank you for the opportunity, and it's been a very nice experience being here. I've learned a lot and learned a lot from lots of people here, and it's a unique experience. So thank you for the opportunity. And to start the weekly grand rounds, I believe it's the last one of the year.
Mhm.
So my name is David Chiang. I'm ophthalmology resident at Hospital Rodolfo Robles, and so to start, um, so the patient's data about this case, it's a male patient, 84-year-old male patient that's resident from Tecunuman, San Marcos, and he's in agriculture. So on the patient's history, everything was denied. I mean, no medical history, surgical history, ophthalmologic history, and also no allergies. The patient first came to us on November the 28th, and his main complaint was intense right hemicranial headache and right ocular pain, very intense ocular pain 8 days prior to consultation. So it's worth to mention that the patient consulted another physician. He said it was not an ophthalmologist or an eye doctor, but that that physician prescribed chloramphenicol plus dexamethasone eye drops, having no relief on his symptoms. So the patient he was complaining about the right eye. So his left eye was basically visual acuity 2100 and only a nasal pterygium and heron toxin. And also there was no other alteration found at the moment. Uh, he had nuclear sclerosis cataract. It was very considerable. But on the eye, he was complaining about he had a visual acuity of light perception, a little bit of eyelid edema on the upper eyelid, also injection on the conjunctiva, nasal pterygium, also a corneal edema, mainly stromal edema. And also we had at the anterior chamber some we saw a deep anterior chamber iridodonesis, phacodonesis. It was very considerable phacodonesis. And we also found some white lens-like material behind the pupil and about the iris inferiorly, and also some flare. So I'm gonna show the pictures just after this. And the pupil was in mid-mydriasis, not reactive to light. We saw a lens, a cataract, nuclear sclerotic cataract, also cortical component there. It was kind of a mature, mature cataract. And we had the IOP that was 36 millimeters of mercury. And also gonioscopy was not able, we were not able to see any structures in the angle. But on his
David,
left, we saw
David,
the,
one question I have for you. This is a discussion we've had with the other ophthalmologists. Is you note the pupil size and that the direct reaction to light is noted, but you do not mention the consensual reaction. So I'm wondering if you know or not whether that was checked and whether there's a afferent pupillary defect on the right side or not. You
yes,
may not.
so the patient did have a pupillary defect on that one, a consensual pupillary defect. Um,
So
I, I
that would suggest that that pressure has caused maybe some damage. Then is that would okay?
yes, I forgot to put that there, but we
Okay.
did perform that test, and we found that too.
Okay.
But yeah, that's very important too. So thank you, doctor, for that. So these are the pictures of the right eye on the first visit. We see there the corneal edema and also this lens, white material, lens-like material, and that it's at the pupil and at the anterior chamber, just inferiorly at the iris. And we can see the kind of dense cataract that he has in there. Um, and on the left eye, basically the nasal pterygium, also cataract. So the moment we made the diagnosis as a phacolytic glaucoma, OD and also pterygium on both eyes. And the treatment that was given to the patient at that moment, it's timolol, brimonidine, dorzolamide every 12 hours on the right eye, acetazolamide at 250 milligrams by mouth every 8 hours, Pred Forte twice a day, atropine every 8 hours, prednisone 50 milligrams by mouth every day. And we suggested, we told the patient that he should return on the next day at 24 hours. So it's also worth mentioning that we did apply drops to the patient before leaving a triple therapy, and the patient then felt a lot of relief about the pain and also the headache that he was having. So at the moment we did the exam at the lamp, the patient could barely uh, he was feeling a lot of pain, so we could barely touch his eyelid, and he was in a lot of pain. So, and we did explain a lot to him.
That's interesting. He's in a lot of pain.
Uh,
Does that's does that surprise anybody else that that uveitis from and pressure of 36 would be painful to the touch?
I
That's
mean,
the
it's probably not.
reason that we
he
asked.
had to
Sorry,
undergo surgery because that's the treatment.
that's the reason, Dr. Sorenson, that we asked the patient to come back the 24 hours after start the treatment, because it was really weird for us that he was so painful when we touched the eyelid. I mean, that's something more like an endophthalmitis or something else.
Mhm.
But yeah, it was really weird because we barely can touch the eyelids, and he was like very like reactive to that. So that's the reason that we asked the patient to come back in 24 hours.
Hmm. Hmm. Interesting.
Okay. So on the next day, the patient told us he had a lot of pain relief. Visual acuity was still light perception, and the IOP was 23 millimeters of mercury. So we had a lot of improvement there. Also, it still persisted a conjunctival injection, corneal edema, also flare, and the lens material at the anterior chamber was basically the same. These are the pictures comparing day 1 versus day 2. Um, Basically not much of a difference, maybe a little bit of improvement in the corneal edema, but we can see still the lens-like material that was at the anterior chamber. So the treatment was kept the same. It was very inflamed at the moment, and we suggested for the patient to return to the clinic in like 7 days for cataract extraction as a surgery plan, because it was very inflamed, and we would like to give him more time to treat the acute um, the acute part of this disease he was coming with. So, and then after that, it's worth mentioning that the patient has not come here to the clinic since that day on November the 29th, because he reported as flu-like symptoms. He said he was having some fevers, lots of flu-like symptoms, of coughing a lot. We even tried to contact the patient. That's what he told us, but he was well aware that it's a very, very delicate situation, and that he had to undergo surgery for an improvement on his pain, and maybe try to save that light perception, or maybe kind of improve a little bit. So, but he did have the pupillary defect, so we thought maybe just save like the light perception, visual acuity. And so to talk a little bit about phacolytic glaucoma, just as a reminder.
Okay, Dave, let me interrupt you one more time. So just getting back to the pupillary defect and how much vision you could save and I'm interested to know what people think about this, but if you are checking for a relative afferent pupillar defect and there's a very small RAPD, that would to me be very different than saying there was a 3 out of 4 RAPD. Um, if I would think if the pressure's 36 and it had been painful for, a few days or a week, and you had like a grade 1 relative afferent pupillar defect, that would be, pretty high likelihood that you could really help the vision. Whereas if you have barely any reaction and a nearly complete RAPD, then that seems like a light perception outcome. I'm just wondering if anybody else, how important is that sign? Do you think anybody else or David in in estimating how much vision has been damaged or lost?
I think it's a good point, Andy. The thing is, I think there's very few people who could tell you if you had 10 people and you said, "Tell me, is this a 2+ APD or a 3+ APD?" If you got 10 people, they're going to give you 10 different answers. But if you say, "Is this a 1+ or a 4+?" Yes, I think you get consensus there. But I think it's a good point. It kind of demonstrates your how quickly you want to intervene.
Mm-hmm.
But I'm still kind of curious if we're definitely settled on the diagnosis of phacolytic glaucoma. I mean, it does seem like a pretty obvious case, but just with that much pain and inflammation, it does make you wonder about an occult foreign body or other type of etiologies. I just throw that out.
Yeah, it could be chronic glaucoma and
I mean,
something
the other
else.
thing is I've had patients with severe pseudoexfoliation that presented really exactly this way. They look like phacolytic, but because there's so much fluffy stuff and inflammation. I'd be curious if some of the others like Melanie have seen that, but I've definitely had cases of pseudoexfoliation present with this level of inflammation.
Yeah, we discussed that with Melanie too, because we were thinking too that maybe it was just like a cute presentation of a pseudoexfoliative glaucoma and just or a traumatic glaucoma that the patient did not refer in the history because it was a very bad history. He just said that it was from 8 days ago, but we were thinking that too, that it was just a pseudoexfoliative glaucoma that came that day or with 8 days of presentation, but it was that from the beginning and not a phacolytic glaucoma.
I mean, in answer to the Dr. Sorensen's question, me personally, whether I saw a 1+ APD or a 3 or 4+, I would still try to intervene and remove the lens. That's my opinion on that. But I recognize that you may not be expecting good vision, if it's a big APD.
Are you comfortable with the waiting for a week?
If the pressure's 23, yeah, probably, yeah. To quiet the eye down, get the cornea clear. If you get the pressure down around 20, I would be comfortable. Yeah, definitely. I mean, because if you go from 38 to 20, I mean, the nerve's going to get a little breathing room there, even if it's pretty advanced. You certainly don't want to wait around a long time, but I think the benefits of improved surgical outcome are worth it. So I would be willing to wait. A cautionary tale, though, I had a case similar to this, but it wasn't. It was in the setting of trauma. Patient, I saw them in the ER, similar presentation, and they did not follow up at my office because I decided not to intervene right then. He did, however, come back a year later with a total cup, a pressure of 50, and a completely reabsorbed lens. So I felt a little bad about that. I'm not sure I would have done anything different.
Wow.
If he had kept his follow-up, it would have been fine. But, anyway, that's the natural history of this for what it's worth.
Okay, David, back to you.
Thank you. Sorry. Yeah, so to just a quick reminder for the phacolytic glaucoma, we should know or keep in mind the mechanism for the glaucoma in these types of cases. It's an inflammatory process, and we see a lot of leakage of the lens material through the capsule of a mature or typically a hypermature cataract, altered lens protein, macrophages, and also other inflammatory cells have been seen on the aqueous humor testing. So on macrophages, the role on this type of glaucoma is kind of unclear, but it's been said that maybe they may be present simply as scavengers of lens material in the anterior chamber, clearing the lens protein from the outflow pathways. And these inflammatory cells would lead also to trabecular meshwork obstruction and precipitate the glaucoma. So basically, the clinical findings that we have on these patients are rapid onset of pain and redness, extremely high intraocular pressure with an open angle, corneal epithelial edema, and the cataract has to be usually hypermature or mature cataracts, white material patches, and inflammatory precipitates. So in these cases, all
David, we're losing you here a little bit.
um
If you come back in. David, we just lost your last 20 seconds there. Or more. Can everybody else hear me? Or is it just
I can hear you, but
Yeah.
maybe just while we're waiting for him to chime back in, I was just going to throw something into the discussion here because I think it might be relevant.
There's a problem with the connection. They're trying to
cataractous
work
lens
with
is
the connection.
dislocated
Sorry.
into the vitreous cavity, and either spontaneously or as a result of a trauma. So that la conexión es inestable. Can you hear me now?
Yeah, now we have you, David. Good.
Okay. Thank you. So also, I was talking about the inflammatory precipitates, but that's very important because there are some differential diagnoses that I would like to talk about later. But then, so the treatment for these cases are topical corticosteroids, IOP lowering agents as beta blockers, brimonidine, carbonic anhydrase inhibitors, osmotic agents, cycloplegics. So we used atropine on this patient, and cataract surgery is the definitive treatment for this case. And usually the IOP would return to normal within a few days after cataract surgery. And it's also said that typically this kind of glaucoma is recalcitrant to medical anti-glaucoma and anti-inflammatory therapy. So that's why the cataract surgery is the definitive treatment for this. So I found this study that talks about the safety and efficacy of manual small incision cataract surgery for phacolytic glaucoma. This study was basically saying that M6 would be, they performed this surgery on 30 eyes with phacolytic glaucoma, and they saw that M6 would be a safer option to perform cataract surgery than phaco, because in these cases, nuclei are typically very dense and hard, and the capsule and sonules are often compromised, giving little support, and there is a higher risk of endothelial damage. And in contrast, M6 places less stress in the sonules and does not require expensive equipment like phaco, and the anterior chamber is like kind of more stable due to the shelving scleral wound that's performed on this surgery. So basically what they did here is like an M6, like a typical M6, but with the cystotome, just perforate the anterior capsule and kind of try to aspirate if there is any material, lens material, and then perform a circular continuous capsulorhexis. And after that, before extracting the cataract, fill the capsular bag with viscoelastic. That's basically like the difference that they performed to what a typical M6 surgery would be, or at least what we do in here. So that's very interesting, and maybe a question for later. What would other doctors prefer in these kind of cases? What kind of technique? That's kind of what I'm curious about any experience you might have with this. And the diagnosis is typically a painful eye with photophobia, decreased vision, and severe conjunctival hyperemia, often in an older patient with a history of poor vision. And all the clinical findings as prominent cell or white material particles in the anterior chamber, flare reaction like our patient had, without keratic precipitates. So that depends on the literature, because some say that this keratic precipitates is distinguished with the phacoantigenic glaucoma, which does have this kind of keratic precipitates, and the aqueous humor sampling that would be like the diagnosis that would be how you would make really that diagnosis of this kind of glaucoma. And to talk about the differential diagnosis, basically phacoantigenic glaucoma, pseudoexfoliative glaucoma, endophthalmitis, and phacomorphic glaucoma. So we talked about the possibility of being a phacomorphic glaucoma with Pamela and the others here. What if it was at the moment, because the eye had a lot of phacodonesis, it was a very severe phacodonesis. What if maybe the cataract was like very big cataract causing a phacomorphic glaucoma at one moment, and then it got like the sonules kind of loosened up, and then the lens was moving all over the place. But that would also tell you like, well, if it kind of loosened up and it was not causing that kind of volume there, then the IOP would kind of return to normal maybe. So that's basically what I had for you today. These are my references, and thank you. Any questions?
Any questions for David? I think I think in my 25 years, I've seen those a handful of times. A couple times in the U.S., it's not that common, but we do see it in these delayed access to care cases. Certainly seen many more in Nuevo Progreso over the years. And is there any particular difficulty you expect to see, David, with the cataract surgery? It's phacolytic. There's, the pressure's under control. Do you think that do you think this is going to be a harder surgery, or do you expect that it's just going to behave like a normal white cataract? What other things might you expect to see during when you do the capsulorhexis? What might be something commonly found?
Yeah, so what I would expect is if there's like a sonular weakness, it would be a more difficult capsulorhexis to be done, because you wouldn't have like the tension you need maybe, or that we're kind of used to, at least what I'm used to, the tension for making at the anterior capsule to make the capsulorhexis. And of course also the risk of causing a sonular dialysis and causing damage to the sonules and all the back, that it could even go to the vitreous cavity. And we would have to be more careful at the moment of aspirating all those material out of the bag. And so at one moment we thought it would be a good idea, or just to consider an intracap extraction because of the phacodonesis that was there, iridodonesis. So that's what we thought at the moment that we would have to have in mind at the moment of surgery.
Well, a follow-up question is, I think we've all seen a lot of Morgagnian cataracts where the nucleus has fallen and the cortex is liquefied. And I don't have any knowledge of this, but I'm wondering why those eyes don't present regularly with phacolytic glaucoma since the lens is already liquefied. I don't know if there's any, I was just throwing that out there. I don't have an answer to it.
I have a theory on that I can throw out.
Let's hear it.
Okay. I think it has to do with the pressure. When you get some of these lenses that there's like a high osmotic gradient. So, you know, when you get the Argentinian flag sign, we've all gotten that, right? If you don't know what I'm talking about, someday you will. Anyway, it's under so much pressure, and I think that contributes to this compared to the Morgagnian, my theory on that.
That's interesting.
But I wanted to just throw out a couple things. As far as the differential diagnosis goes, one other consideration in a case that presents with an inflamed eye and high eye pressure is HSV uveitis. And it can appear with a variety of different types of KP. You know, a lot of times classically, it's more of a fine KP as opposed to the phacolytic. You get the more big fat KP. But I think that HSV is an important thing on the differential for uveitis with high IOP. Not talking like 25, but like 38, 40, because they get a trabeculitis. That was one comment. And the other comment that I would have to make is that I would disagree with the conclusions of the study. I mean, not really disagree. I think that's perfectly fine. But I personally would always phaco these if I have enough visualization. I'm very confident that I can produce a more rapid recovery and do it safely, even in the situation with somewhat unstable zonules. But there's some important modifications to your technique if the nucleus is hard. Two modifications that I would make if there's a really hard nucleus and I don't want to stress the zonules at all are, if you're used to using a 30-degree Kelman tip, which I think last time was at the hospital is what you had, switch over to a 45-degree Kelman tip, which, you know, I'm sure Andy has used those. Some of you might have used those. They're a little scary looking, but they're extremely efficient at cutting. So that's number one. And number two, if you're used to using a lot of rotational phaco, switching over to adding longitudinal phaco to the mix in addition. And I think if you do those two things, you're going to have a very efficient phaco needle that will really cut through a very, very hard lens with very little trauma. And then I'm going to end up with hopefully not much wound burn. I'm going to have a smaller incision. I'm going to have a stable anterior chamber. And so for those reasons, I personally am very comfortable phacoing these eyes and probably wouldn't do manual if I had the resources. Obviously, there's a cost difference.
Thanks, Eric. Rupert, you have your hand up. I think that's Rupert.
Yeah, it is. Thank you. Andy, you and I have had this conversation about pupils. So I was just curious, quick survey. Do most people check pupils routinely in their office, or are you just checking them when you suspect there's going to be an APD? Because, you know, it's hard to know what's abnormal when you don't know what normal is. And if we're not checking pupils routinely, it can be difficult. So I was just curious, do people check them routinely or not?
Yeah, I think, well, maybe that's a survey question.
Yes.
Amy, I mean, I think they should be checked on every single person without fail. And I would add to that I take a little issue with 10 people producing 10 answers, because I think there is a scale that can be objective if you have, you know, if everybody's working with the same experience level. I think you'd say, you know, we all now agree that, I mean, if a pupil goes from 5 to 1 and it's an afferent pupil, that's not a 4+ pupillary defect. But I agree. There's going to be some subjective. Amy, go ahead. I got unmute.
I'm just trying to unmute. Can you hear me?
Yeah, yep.
Okay. So hi, David. It's really great to hear your voice and see you. Great presentation. I'm curious, do you typically get a posterior segment inflammation when you have phacolytic glaucoma like this? Because it would make sense that the lens would be also causing inflammation posterior. And I may have missed it, but was a B scan done, or did you have a view to the posterior pole to see if there's any vitritis or anything?
Yeah, so unfortunately, it wasn't possible to perform a B scan at the to the patient because we were having some trouble with the B scan. We were not able to perform one, but yes, it would. Well, I would expect that the patient could have some posterior inflammation too, because of the lens material and all the proteins and everything that could cause that.
Interesting. All right, David, that's a great presentation, and thank everyone for joining in tonight. And again, happy holidays, Merry Christmas, and New Year. We're good. This is our last grand rounds of this season. I think this completes our second calendar year. Jorge will continue leading this in our calendar year beginning in January. I don't have the dates out yet, but that's what we'll be looking for. And nothing else to add. Thanks everybody for coming, and hope you have safe and healthy season with your family.